welcome to another episode of Accreditation TV. Today, we're going to talk about a subject that has been much talked about over the years, temperature and humidity. And I've got two of my favorite subject matter experts with me. Of course, we got Tim Adams, who really needs no introduction in the facility environment space. Everybody knows who Tim is. He's been around. I don't know. I shouldn't say I had been around a long time. You've been
It's
around a
been a long
while.
time.
Been a long time. Worked with Ashy for a while. Man, we go back how many decades? I don't know how far we go back, but it's been a long time, and we've shared a lot of educational sessions and done a lot of presentations and taught programs and just had a lot of fun preaching the patient safety gospel together. I think is a great way to say it. And then, of course, we got Edwin Lofton, Dr. Edwin Lofton, sorry, and no offense, who everybody, if you've watched some of these videos, you know that Edwin and I grew up together in Eastern North Carolina, which means we are really well acquainted with temperature and humidity. But we're not going to talk about how it impacts life in the tobacco field today, Edwin. We're going to talk about how it impacts life in the hospital. Before we get into the specifics, though, I want to remind the people that are a part of our accreditation readiness network. If you want CECs, jump on over there. We'll get them for you. And if you're not a member of the ARN and you want to be, reach out to us. You just jump into our website there, and we'll capture your information and we'll reach right out to you. So let's just kind of get cranking, guys. This is one of those things. I was having this discussion actually recently with a friend of mine that's a physician, and we were talking about uh, just some of the challenges related to issues that have been ongoing for what feels like our whole careers. And this is one of this falls into that category, right? Temperature and humidity and the constant battle between let's strip out for a minute the whole compliance. I know we're talking about accreditation and compliance, but let's just forget about compliance for a minute. We'll talk about the constant battle between facilities people and clinical people related to temperature and humidity. And I've been in Bolden and been caught in the middle of a bunch of those battles over the years myself personally, and I know probably that both of you have as well. Um, but there seems to be this kind of constant divide between those two parties and to where temperature and humidity ought to be within the building. And part of it has to do, and I'll start with Tim, is kind of the laws of physics, right? It's like, there's temperature and there's humidity, and those two are related.
Yeah. Inter interlinked. If we um, measured relative humidity in a space, measured the temperature, if we lowered the temperature but no moisture comes in, the relative humidity increases, and vice
Right.
versa. So lowering temperature, when uh, that happens naturally, or somebody says I want it colder, is also going to affect humidity, and we have to look at those hand in hand. And there are those things we call regulatory requirements that center around how we design facilities to have a range of, in many spaces, not every space, but in many spaces, a range of relative humidity, or at least a maximum, and a range of temperature. And those are very dynamic things. I live in the Midwest, the part of the country you live in. Right now is a great example. We'll have snow and pretty low humidity outside, and then it rains the next day, and we have some tornadoes and stuff. And the relative humidity is sky high. Inside the building, that's happening too. It's going up and down. We're drawing in air with a whole lot of moisture that yesterday we were drawing in dry air. That changes the dynamic. And then we add to that fluctuation in our systems. I think folks, especially that don't have experience in the facility management side of things, systems have an absolute limit that they cannot suck any more moisture out of the air, or put any more moisture in the air, or can't lower the temperature anymore. There are fixed limits, and occasionally our systems get pushed to that limit. We try to operate in a sweet spot, but we can get pushed to that spot where it can't take any more moisture out of the air and the relative humidity is going to climb.
And that's I think there's 2 points you touched on that are really important here. One is and it's for infection prevention purposes primarily, but we are required, and now we're getting into the codes, but we're not gonna go there just yet, to have so much outside air all the time. So we're constantly the what's happening outside of the building has a great deal of impact, not only on temperature and humidity, but also air quality. And that's a whole nother, we'll do that in a whole nother session. We'll talk about air quality because that's something I think we need to get into. Um, but then there's the whole understanding of relative humidity and its relationship to temperature. And I can recall very vividly standing in an operating room with a cardiothoracic surgeon yelling at me saying, why can I not make this 64 degrees in this room? And we were very delicately trying to explain to this person why, what would happen to the relative humidity. And, being the kind of guy that I am, the, Mr. Analogy metaphor dude, I was like, if you had a sponge and think of it this way, you got a sponge and it's got so much water in the sponge, and then you lower the temperature and that effect squeezes the sponge. And so the percentage of moisture in the sponge is now higher than it was. And he's like, you know what? I turned the thermostat down and nobody squeezes my operating room. Um, and so I lost that argument temporarily anyway. But so from, Ed, when you dealt with the clinical side of this your whole career, right? Most of it anyway.
Yep.
And what is, from your perspective, aside, I know we got comfort, right? And we also got infection control, but what were some of the challenges from a temperature and humidity perspective?
Well, this is, and you, Steve and Tim, you've already hit on it very well. This is one of the classic points of argument between facilities management and clinicians over the years. And OR is not the only place, and we'll talk about other places as well, but it's a great place to begin the conversation. The technology used in the operating room suite has changed over the years. It used to be the surgeon and the circulating nurse wore a mask and a hat and a gown and gloves, and that was it. Well, then all of a sudden, especially in orthopedic and cardiothoracic cases, you started adding much more gear and hoods and devices that create an internal thermometer that you can't control. And so their first reaction when they've got the hood and the gowns and everything else on is turn up the air conditioning. What we as an industry failed to do, and hopefully this is a place that we can recover from that, is have the conversation between the clinicians and life safety personnel prior to the event. Let's come to a shared understanding. And so, Steve, like your conversation with the cardiothoracic surgeon, if that could have been had before the time in the operating room suite, and there could have been a negotiated space that met the compliance, that would make a much better way. But especially as technology changes, that we've got to think ahead and have these conversations, one, to protect patient safety always, but also to create an environment that the clinicians can work in. And three, just as equally, create an environment that life safety from a code management perspective, from an infection control perspective, from a fire hazard perspective, can manage all at the same time. This is not just juggling 3 balls. This is juggling about 10 or 12 balls, which I can't juggle one.
Yeah.
But this is where we have that conversation.
Yeah, I think part of it comes down to mutually understanding where, what's the end game here. And what, what ultimately happened was we did have a follow-up conversation that was much more calm and peaceful. And, where they said, this is why, we need it cooler. And in fact, the conversation started with we want it to go from 72 to 64, and we want it to happen in a very short period of time. And going back to your engineering discussion, Tim, is like you've got the limits of what a system can actually do. And I recall I remember picking up the phone and calling the smartest engineer I've ever met in my life, smartest person probably ever met in my life, Ed Tinsley. Sorry, Ed, for bringing you up here in public domain. And I asked him, I was like, can you even do what he wants? And he goes, oh, yeah, of course you can do it. They can't afford it, but it can be done. You know? And you wouldn't want to be in the room when it's happening. But when we finally had a calm conversation, like this is why it matters for the patient, and then we explained, okay, it's not just because the Joint Commission says, and it's not just because ASHRAE says, this is why it matters, not only to this patient, but every patient that might use that room in the future, that all of a sudden you start to get the compromise that didn't seem to exist before. So now that we kind of laid that groundwork, why don't we talk a little bit about the actual compliance part of this, right? And y'all both touched upon it already, but yeah, we do have a set of fundamental standards. Um, and I think it will be interesting to talk about the fact that there's more than one here in a minute that causes some conflict from time to time. We, as the facility people, when I say we, I'm talking about Tim and I, and then all of our colleagues behind us that might be listening to this presentation, we tend to gravitate usually more towards the Facility Guidelines Institute because that's a requirement inside the Joint Commission standards. For one, a lot of the states have adopted various versions of that document. And they have adopted the ASHRAE 170 document, which gives us some very specific guidelines around temperature and humidity, space by space by space. And then there's another document that's out there that is, and I'm blanking on, AORN has a document that they use that has some very specific guidelines around temperature and humidity from specific spaces. The challenging thing about that is they are different from one another. But the clinical people, Edwin, I think tend to gravitate more towards AORN, right? Which stands for what? Association of Operating Room.
Operating room nurses.
Wow. I am not as old as I thought I was. At least senility's only partially crept in. So, one of the where we've run into code compliance issues or accreditation readiness issues is when the clinical side of the house is using AORN for their benchmarking, but we've built the building using ASHRAE and facility guidelines. And those two, if we're maintaining it to one standard, it's unlikely to meet the requirements of the other. Um, have you guys run into that or seen that anywhere yourselves?
It's very common. And, one of our challenges, just to add to the regulatory burden and the number of authorities having jurisdiction, we call them, that are involved, most states are going to have requirements that at least minimum requirements that you build to. And you may
Yeah.
have a building 20 years old that was built to the standard in effect, and it can still operate at that. It's allowed to continue to operate. But you can't apply newer standards to that and expect the system to be able to do it. So
Right.
a starting point just about has to be, what was our building and our system or ventilation systems designed to do? Can it still do that? And does it have any more capability beyond what it was designed to? Because that will be a limiting factor in what we do.
Yeah,
And
so let's talk
Well,
about that for just a minute. So let's say, and please don't do this, Ted, but let's say someone calls you from a hospital that was built in, let's say 2016 and says, Tim, we need your help. Come run our facility for a few years. Um, and so it was built on the 2014 standards, for
Mhm.
example. you know, what what I hear you saying and what we always recommend is that you establish in your policies and procedures the fact that this building was constructed under the 2014 guidelines, which referenced this set of the ASHRAE 170. And here were the guidelines and the specifications it was constructed to, what it was capable of. And that was the standard that we maintain it to now. Because in the absence of that, when you're being surveyed by whoever the accreditation organization is, whether it's, Joint Commission, DMV, CMS, whoever, they're going to hold you to the newest standard because that's what they have available to them. Is correct?
Yes, and I I think it is so critical that an organization understand what they were designed to, what the state or whatever authority approves their building, usually the state, what it was designed to. And you may have operating rooms that are designed to do different standards. Very, very common. Old part of the building may only have 15 air changes per hour in the
Yeah.
operating room. New building or newer is 20 air changes per hour. And that's okay. But that does provide some limitations. But it's from an accrediting standpoint, it's very important to be able to explain to whatever agency or organization it is, this is what we were designed to, what standard, what was approved for this building, what parameters, this is this, and then this is what we operate at. Then the next step of that is, say we have an older building that has less air changes, which were allowed years and years ago. Um,
Yeah.
but we're wanting to do these rapid temperature changes and things like that. It just doesn't have the capability.
Right.
It takes a lot of air to make that happen, and a system has a maximum amount. You just can't push it any farther. It can't do anything more. So that starting point has got to be, what is it designed to do? Um, what was the standard at the time? Does it still meet that standard? And is it still functioning? And then we could talk about, is there any other capability? But we have to go back to what it was designed for.
Yeah.
Tim, in addition to understanding the capacity of existing facilities and older structures, I'm going to be a broken record. This is an opportunity when you go in and renovate a space or build new space, the value and the importance of bringing infection prevention, clinicians, life safety all together in that design part. In 2021, I was a chief operating officer, and we were redesigning the waiting space of our emergency room related to COVID and other infectious disease processes. And so we brought everybody together: life safety, infection prevention, the physicians, family members, family advocates, and nurses and clinicians together, and had these conversations about what is the regulatory component, what's the code compliance, what's the comfort compliance, what's the patient safety compliance. And with that, while it took a little bit longer than some people wanted, the result was we had buy-in from every constituent that was going to be using that space moving in the future. So
Yeah.
again, this is a great opportunity in healthcare to promote patient safety and have people work together.
Yeah, by the way, what you just described without actually knowing it is the FGI's requirement for a functional risk assessment being done. I mean, that's really the intent behind that. Does that actually happen in that manner in reality often? Probably not as much as it should. It's
Right.
usually that it's done more typically by the design people because a lot of times, no offense to the clinical team, they don't want to be involved. And so
Mhm.
you know, it having that kind of uh, discussion and being understanding here's what we can do and then what we should do well before we ever put when nobody puts pen to paper. Edwin and I actually took drafting class together
That's right.
back in the day. So we put pen to paper, but now everybody puts mouse to mouse pad, I guess, or what? I don't even know how they do CAD anymore. And that's how old I am. But before anybody starts actually doing the design, you've had those discussions and you understand how you're going to use that space. So, thinking about this purely from an accreditation standpoint now, which is, why most people are probably tuning in, we see very common um, patterns, right? Places that every hospital struggles with temperature and humidity. The ORs are obviously the most common one, right? Because of what Edwin described, and the reality is, most of the buildings are older. The technology has changed. I mean, computers, everything runs on a computer and a microchip now, and they generate a lot of heat. Most of those rooms when they were designed, the heat load that they're experiencing now, nobody could have anticipated, right? So we have that challenge to deal with. And then on top of that, the PPE, as you pointed out, the personal protective equipment, I should probably not be Mr. Acronym today. Um, that has changed as well, right? So the where the technology and the way that we deliver the care has evolved, the rooms have not changed. So OR's specifically a problem. So constantly we're seeing out of range either on temperature, or more commonly we see out of range on relative humidity. Um, from a Go ahead, Edwin.
I was gonna say another space, and it just reminded me of it, that this comes into play with temperature and humidity and the change in technology, is the hospital laboratories. In a
Oh yeah,
lab, and in the 70s, in the lab, you would have the technicians behind a microscope, and they'd be counting a differential by hand. Well, we've added computers. To your point, Steve, we've added massive amounts of computer technology, and the heat generated from those spaces typically outburden the existing HVAC systems. Back to Tim's point, that the system has no way of compliance, and so you are constantly out of humidity range in the micro lab, which is not a good place to do that in. You've got real issues there. So again, that planning comes into play.
yeah. So, I mean, for the non-engineer types on the that are watching this, I mean, if you think about it, when temperature goes up, it's like putting a sponge in water and letting it expand. The air gets bigger, molecules spread apart, and it support more moisture in the air. And so we actually take more water vapor into the air. And then when we lower temperature, we reduce the volume. And so that relative humidity, that's why we use the term relative, actually goes up by a percentage. And so we're constrained from a compliance perspective to certain relative humidity levels. And so just adjusting that thermostat up and down has a dramatic effect on whether we're in compliance or we're not in compliance. Oftentimes what we see, well, we're seeing actually two different things. We'll see in a lot of times in the summertime, in particular, out of range high in the ORs. The biggest concern that we have with outer range high, if it persists like that a long time, it means there's a lot of moisture in the air that potentially could become a problem and for supporting the growth of, as one of my clients likes to use the phrase, potentially organic material. Um, but supports the growth of mold, right? Which is obviously something we don't want in the hours. Then the other side is in the wintertime, as Tim just talked about with Bloomington area being, it gets really cold. It's been really cold here, and the temperature, I mean, the humidity was down in the 8 to 10% range. When you get way down there, now you're concerned in the OR about static electricity and the potential for an OR site fire. Right, so it's two totally different things, but equally hazardous to patient care. Um, so part of the decision, realizing that what we've already established the fact that the systems are only so capable, then the question becomes, who makes the decision whether or not to suspend services in a room because we're out of range high or out of range low? And I'll just let either one of you guys or both of you guys to weigh in on that.
Well, I'll jump in. Because things do not happen instantaneously, um, we can't instantaneously change temperature or humidity. We don't instantaneously have mold growing.
Yeah.
Um, we don't
That's a good thing.
we don't instantaneously destroy every sterile material we have in a space. I think it's very wise of an organization with a team effort. This should not be a facilities only or infection prevention only or OR only decision, but to build into our policy and practice a little buffer space. So if we're in a uh, area where we store sterilized packs and the relative humidity creeps above 60%, which is the upper limit, do an immediate risk assessment. Are things damp? Is it raining? If you touch metal, does it feel damp? Do an immediate risk assessment. No, it doesn't. Build into our plan then a little bit of time and let the
Mm,
system try to catch up. And then make that plan where it escalates. So if whatever time frame you decide on, if the humidity has not come down, then we will escalate to the next step. Perhaps facility management is going to um, see if there's any kind of adjustment or remediation that they can do. And again, we are monitoring the environment. Is anything bad happening? Are we sensing moisture? Um, Same issue could be applied in the OR. If we are, if our humidity drops whatever we use for the lower limit, if our policy says we use 30%, or if we're using 20%, that's a whole other discussion too.
yeah.
But
Well, we should touch on that waiver briefly, and then we'll follow up with a more detailed video on that, I think.
yeah, that you can in the past, and I guess we'll just do it right now if that's all right. In the past, you
Sure.
could have or the lower limit for relative humidity was 30%. Newer editions of ASHRAE 170, which is incorporated into the FGI guidelines, which is used by lots and lots of states, um, allow going to 20%. But if you're going to go below that, if you're going to go below the 30% and use 20% as your low limit, you need to do a risk assessment to determine, are your supplies and is your equipment, um, does the in manufacturer's instructions for use allow it to be in that humidity range, lower than 30%. And and obviously that has to be done ahead of time. This is a
Right.
kind of a organization discussion that needs to take place and make a decision. If you are allowing 20% and it drops below that, do an immediate risk assessment. Um, where are we at in the case? Are we doing prep with flammable stuff, or has the case already started? Are we using electrosurgery? Are we using lasers? Um, in the OR, we're probably going to have to continue doing the case.
Yeah.
There's many points you can't just stop, but we need to monitor what are our conditions and give it a little time to catch up. That humidity might correct itself in a fairly short amount of time as humidifiers kick in and the system moves air and does all the things it does. But assess the immediate risk and then have that period of time for the system to stabilize, and then an escalation. And that escalation may very well be come to the point when this case is done, we're not doing any more cases in this room. We cannot get the humidity back above 20% or 30%, whatever you're using in your organization.
Yeah.
But um, put some time in your plan, and don't stop everything immediately. Just assess, is there risk, and let the system have time to catch up. And the authorities that we've talked to are very very good with that. Actually recommend it. You don't want to be doing drastic and crazy things when your humidity is 1% above 60. it
Yeah.
it
But Tim,
probably will
and
come back
Tim,
down.
and Tim, what you're describing also is covered in the A360 standards that Joint Commission is now using under EM 12.0201, in that your emergency management plan must have that risk assessment thought out in ahead of time. So you made your point very well. This is not something you decide on the fly. You've got to think through and give the alternatives.
Yeah, and I think it's important and because I don't know, our audience is so diverse. It's there's facility people, there's quality people, there's infection control people, everybody, even C-suite people that are watching these videos. Thank you all, by the way, for your time. But these the standards by the manufacturer's recommendations that establish that 30%. The problem is usually the 30% lower humidity Well, obviously, because with the waivers for going to 20 out, that would be where the problem would be. Um, but most of those are established because that was the code at the time. And it was easy for them just to say, store it within this range or use it within this range. And the fact is, there's not a lot of science behind that. The problem is the manufacturers, if you go to them and request, a waiver, if you will, from them, they're very reluctant to do it because they haven't done any kind of testing and they're not going to do any kind of testing. So they just go, well, no, we say, it's got to be 30%, it's got to be 30%. It's much more a risk management decision on their end than it is a science, technology, and engineering decision, which is a little bit a shame. But they did it become rest on us to do that risk assessment, decide as a team. And this is where I think our facilities people need to support the clinical people. And eventually I'm going to get around to using an aviation analogy here, right? It just happens every time. But in this situation where, if you're a pilot, you're flying a small airplane and a big jet takes off in front of you, the controllers are going to say, caution due to wake turbulence, cleared for takeoff. And what that basically means is, there's wake turbulence out there. It's up to you as the pilot in command to make your own, to decide, is it the risk of it small enough that I'm going to take off or I want to wait till it's clear. That's the same thing that's happening here, in that here's what like Tim just basically described. What are the risks that would occur if it's high, if it's low? We need to communicate that effectively to our clinical colleagues and our organization so they can then go, oh, well, the risk of, okay, the humidity is a little bit high. It's not going to be high for long. We're not worried about infection on this one. It's not going to happen. Versus the other side. And I get a great examples here, and this blew my mind with burn patients. They want the room at like 75 degrees, so which is way out of the temperature range that we're supposed to keep these rooms. And of course, as I mentioned, we've run the temperature way up. We're going to have humidity issues later on. Um, the first time I heard that, I was like, no, absolutely not. Can't do that. But then they explained why they needed to do it, why it was critically important for the patient. Well, oh, okay. Well, then, yeah, we can make that work. So that give and take is really, really important. From getting back to being surveyed. So now we're being surveyed by an accrediting organization, maybe Joint Commission, maybe DMV. They're going to walk in. What do you think their expectations are going to be in terms of documentation, from not only a ongoing surveillance perspective, but what happens when we're out of spec?
Well, they're going to be looking for that full all hazard risk assessment. How have you considered what the potential options are happening related to the actions? The entire conversation we've been having for the past 30 minutes, how did you include the infection prevention team, the clinicians, the life safety? What science was included, and what was the rationale behind your final action plan? So if if an organization has a well documented risk management assessment, then the accrediting bodies are going to be okay with that, especially if it's when it's in compliance with the local governing bodies.
It's important too that regarding the low humidity level in operating rooms, cesarean section, C-section rooms, I can say that easier, and um, even other areas such as a cath lab, if it is treated as an OR, that varies from state to state and what kind of things you do in there. But those areas that are treated as ORs, um, are you using 30% as your lower limit? Are you using 20%? There is a waiver from CMS that CMS sends out periodically, what's called S&C letters, and it will. There is a blanket waiver to use 20%, but you have to let the surveyor know when they come in the door. Not,
Yeah.
oh, our humidity is only 25% today. Well, we're using the waiver. Too late.
Yeah.
You let them
Yeah.
know at the beginning, we use 20%. So it's important that the surveyor be aware of that. And I think, and I still am a believer in policies. It is it is very important that you specify in your policy what your parameters
Mhm.
are and what
Mhm.
your process is, because they will judge, are you following your process? There is no standard that I know of that says if humidity is above 60% for 5 minutes, you have to take action, or 1 hour, or 10 seconds, or half a day. There isn't something that tells us that. We have decided what that's going to be. And then the organization will judge, are we following that?
Yeah. And that's particularly true for, one of the AOs is they are all about what your process is, and if you can articulate the process, that's
Mhm.
what they're gonna hold you to, right? So, I think the other piece that I mean, you guys have heard me preach this probably to the point of you just wanna, do horrible things to me, but, when I think about, when I talk to clients about what should you do from temperature and humidity perspective, the first thing is let's start with an inventory of spaces where it really matters, right? So the ORs, that central sterile, where we're storing sterile supplies, which could be all over the building, and typically are all over the building, which that's a whole nother discussion. Do we really need it there all the time? Because that changes our requirements from a monitoring perspective. But we create that inventory and then we put a process in place to periodically, or if you've got the technology in place to constantly monitor temperature and humidity in those spaces, or well, along with this parameter that says, what do we do when we're out of spec? But to me, the part, and this is part of why I preach too much about this, is that we do that with the idea of, uh, how are the patients actually impacted in this particular space? Like, well, as we say, compliance for the sake of the patient or compliance with purpose, right? And it's, thinking about it from a pressure relationship standpoint, even though there's no requirement for a patient rate to be negative or positive, if you've got patients that are typically immunocompromised, you probably want those rooms to be positive, right? And your point about the cath labs, are they treated as ORs? Are they not? And that a lot of that is dependent upon where they are in the building, right?
And
But go ahead, Tim.
oh yeah, and what procedures you do and what your state
Yeah.
says.
Exactly. And keep in mind though that those things change over time. Maybe not necessarily
Mhm.
appropriately, but we had an experience once where they were doing placing pacemakers in a cath lab that was not considered an OR, so therefore they weren't following the typical fire prevention protocols and ended up having a surgical site fire in a non-surgical area. Just as devastating, if
Mhm.
not more devastating, because they weren't prepared to respond to it because they've never been trained to do it. So, those kinds of things I think are really important when you're starting to put these pieces together. I mean, if you're going to do the work in order to satisfy, whether it's Joint Commission, DMV, CMS, ABC, whoever comes along next, um, do it in a way that satisfies the needs, not only that, but also the patient's infection prevention uh, and provides that level of safety that we all want to provide for our patients. And so, any other thoughts about temperature, humidity?
You What you were just talking about, something very important. This applies to outside of just the realm of temperature and humidity. Whenever a space you're considering changing its use, changing its function, changing, excuse me, what you do in the room, and the cath lab's a perfect example. Maybe we just did diagnostic caths and now we're doing intervention and putting in pacemakers and doing EP, and all of a sudden it's not the cath lab it was before. May look the same, but it's now become an OR. Um, Whenever there's a change in use or function in a space, there should be a multidisciplinary review to be sure we meet all the needs and requirements and functionality of that space. What kind of got me started on this discussion, we talked about it at a meeting we all had together recently. I was doing a survey, and within the OR suite, the surgery area, there was a room that said storage on the door. And of course, I want to go see what kind of storage we have. Opened the door, and
Yeah.
there were a lot of clean supplies and some other stuff, and a rack of packs, sterile packs.
We're
and
back.
said, do you have any temperature humidity monitoring for this space? And said, no, we don't have to do this space. We monitor central storage, central supply, where everything's stored. But these aren't stored there. Well,
Yeah.
sometimes they don't have enough space and they bring a rack up here and store them. You can do that. You've just got to assure that temperature, humidity, pressurization of the space are correct and that you meet other requirements for that to be a clean storage area. There wasn't any thought to that. It was just kind of like, well, it's within surgery. It's probably okay. Um,
Yeah.
that somebody's decision. We've got empty space. Let's use it here. Um, it may very well be the system can provide what you need and it meets the requirements, but you need to be monitoring that and assure that that's the case.
Yeah, and to your point, I mean, we've seen that a bunch of times, right, where that's kind of happened, and as much as I'd like to think, the facilities folks, we know everything. When we discover something like that, that's really Edwin's area of expertise to decide when do they need to reprocess all that material, right? I mean, if it's maybe been out of spec for a few hours. Does that mean that, all that blue wrap stuff needs to go back to SPD and run through, or does it? I'm not, I don't have the experience and knowledge to make that decision. And that's where, we talk a lot about this to the point probably people are getting sick of hearing us talk about, working together as a team and, that kind of cross pollination. But I mean, there's just so many examples where it really, really matters. And this is one of the big ones, the temperature, humidity. And we've done some discussions about pressure relationships. Actually, we've done them, but we've done them inside the R, and we should do another one and talk about pressure relationships in particular, because I think that's something where, we do have a good set of standards and guidelines. Um, but I'm always surprised when talk with clinical counterparts. Sometimes they go, "Well, why is it that way?" Well, we'd prefer it to be this way, or if I'd known that, I would have done something differently. So we'll follow up with that. Any other thoughts for either one of you about this particular
But
thing?
I think in closing, to be completely repetitive, this is a great opportunity for multidisciplinary teamwork for the sake of patient safety.
Yeah, absolutely. And then just making sure, I mean, documentation is king, right? It
Yep.
just, Tim pointed out, you can't pull out a trump card, of spade and say, well, we took the waiver. Sorry, we're at 25%. It's too late for that. So all of this has to be thought of in advance. So you kind of bring it, I think, to just a few bullet points. You want clinical and facilities involved in doing the risk assessment, right? You want to make sure that all these spaces are identified in advance and we know what kind of work is happening there. We're monitoring them continuously so we know when they're out of specification. We've pre-established some guidelines as to when we're going to suspend operations and when we're going to or return to operations based on those guidelines so we can support that if we get challenged during a survey. And we document those activities when they happen so that in the event that we do have a problem with the survey, we can present that data and show, hey, this is what we've been doing. We've been following our guidelines, and this is what we're going to do now, the same process. And the one piece that I'll add, and I haven't really talked about it, is ongoing surveillance from
Yeah.
infection prevention that says we're not having a problem, right? We're not seeing any kind of infections associated with that would be, triggered by anything outside of temperature and humidity. So, anything, I guess that kind of sums it up, doesn't it?
Very good.
Awesome. Well, guys, I appreciate so much your time. And I appreciate certainly the people who've tuned in to watch this. We appreciate your time as well. We look forward to seeing you in the next one. Again, if you're an ARN member and you want those CECs, jump on over there. We'll get those to you. And if there's anything we can do to help you out, just jump on over to mslhealthcare.com and let us know. We look forward to seeing you on the next one. Take care.
Have a good day, everybody.